With that, I want to introduce Dr. Richard Wang. He is an assistant professor of medicine at Cooper University Hospital. He got his medical degree at Peking Union Medical College in Beijing, China, and did his internship at residency at Temple University Hospital. And he did a fellowship in gastroenterology at Mayo Clinic in Jacksonville, Florida. Dr. Wang also has his PhD in health economics from Penn and is an expert in gastroenterology and colorectal cancer. So we're delighted to have him join us. And with that, I want to welcome Dr. Wang.
Thank you. Good evening, everybody. Good evening. Is the mic open? Okay, good. So what I'm going to present in the next 20, 30 minutes, just an overview of colorectal cancer, diagnosis, symptoms, and I'm going to devote the second part of it to the prevention of it, which is most of the things we do every day as a gastroenterologist. If you have any questions about my Chinese English or Chinglish, just raise a hand. I'll try to speak a little slower. It's supposed to be an informal presentation. Just feel free to ask questions along the way. And towards the end, we'll have time to answer your questions, and I'll stay around as well. This is a picturesque view of the colon. It's about 2 to 3 feet long. It's towards the end of the digestive tract. Here you can see it connects with the distal small bowel called the ileum. It starts from the right side where the appendix is attached to. It goes from the ascending colon to the transverse colon, where it's crossed to the left side, and the left descending colon, the sigmoid colon, and towards the end, it's the rectum. So this is a graph from the SEER Cancer Registry in the United States. It tells the incidence of colorectal cancer per 100,000 population by the age breakdown of age group of 5 years. So the x-axis is the patient age. In the middle of it, it's the age cohort between 50 and 54. The y-axis is the incidence of colorectal cancer per 100,000 patients in that age group. Here we see that the incidence or the risk of colon cancer increased dramatically with age. Age 50 to 54, the incidence is only about slightly over 50 per 100,000 population. But then you look at those above age 60, it doubled to over 100. If you look at the age group above 70, it's almost 250 per 100,000 population. So the risk of colon cancer does increase with age. There are various risk factors for colorectal cancer. Age, as we just shown. Sex, it's a higher risk for men than for women. There's also difference in race and ethnic groups. African Americans are at a higher risk for colon cancer. That's why for African Americans, the professional guidelines actually recommend to screening for colorectal cancer at age 45 instead of 50. Also, patients who are obese or lack of exercise, they're at higher risk for colon polyps and therefore colon cancer. Patients with inflammatory bowel disease like Crohn's disease, also colitis, especially those with extensive inflammation in the colon over time, they're at higher risk, and through a different pathway for colon cancer. Patients who had abdominal radiation to treat other cancers because of radiation, they're thought to have a higher risk too. And finally, about 2 to 3% of colon cancer we diagnose are hereditary colon cancers. There's a syndrome called Lynch syndrome, which is linked to right-sided colon cancer at a very young age. Patients with Lynch syndrome or carry the gene, they need to have screening colonoscopy starting at age 25 to 30 and every 1 or 2 years. That's a very special cancer group. This is we saw most of the colon cancer start from. It's just a simple small polyp. This is a little magnified. We see as clear a picture during colonoscopy as this one. Here you can see the raw structure is actually a polyp. The gyrus kind of formation on the polyp is actually the microvessels, and it's different from the background, which is the normal colon mucosa. These polyps, given time, can turn from low-grade to high-grade dysplasia and become invasive. Usually we think it's about 5 to 10 years, depending on other things. So this picture shows the different stages of colorectal cancer, start from mostly a polyp, from low-grade dysplasia to what we call high-grade dysplasia, which is it's cancer cells, but they haven't invaded the mucosa yet. The colon on the right little graph shows there's 4 layers. There's mucosa, submucosa, muscle layers, and there's serosal layers. When the cancer cells start to invade in submucosa, it becomes stage 1 colon cancer, and later on becomes stage 2 when it gets deeper into the colon wall, invading the muscle, and then breaks through the serosa. That's when in stage 3 the cancer could spread to local lymphatic lymph nodes. And later on in stage 4, the cancer cells actually goes to other organs. The most frequent stop, the first stop, is the liver. Cancer can spread by lymphatic vessels or by blood vessels. This is just pictures of you showing actually there are a few on the left lobe of the liver during the surgery. Here, the white nodules are actually the cancer cells spread from the colon to the liver. Colon cancer does have symptoms, but the symptoms are not very specific. The most dominant symptom, based on one large study, is abdominal pain. It's about slightly less than 50%. There could be change in bowel habits, about 43%. This also depends on where the location of the colon cancer is. Colon cancer close to the rectum, they're more likely to cause a change in the shape of the stool or sometimes constipation. While colon cancer on the right colon, they're more likely to cause anemia, some general abdominal pain, but less likely to be constipation. Also, cancer can cause bleeding or cause dark stools, especially for cancer that's become invasive in the right colon. And when the blood travels through the colon, it becomes darker. Some weakness and some weight loss, some non-specific anemia. So it's really a variety of symptoms. Colon cancer, most of the colon cancer are diagnosed by colonoscopy because we need good tissue to confirm pathologically the diagnosis. This is a pictorial view of colonoscopy. We have a flexible tube. After the bowel prep, we go through all the colon to the start. And colonoscopy can be used for other things too. It can be used to check for the distal small bowel for Crohn's disease. It can look for and remove polyps. It can diagnose inflammatory bowel disease such as ulcerative colitis. And it can also diagnose colon cancer. So the treatment, what's the critical part of the treatment is once we diagnose colon cancer, we send the patient to a special type of doctor called oncologist. These are cancer doctors who are internists who specialize in cancer treatment. They're like the quarterback of the football team. They're going to stage the colon cancer to see whether, by CAT scan, looking at the abdomen and the chest to see whether the cancer has or has not spread to the liver or other organs. Is there any lymph nodes that are enlarged? And also, we often check a CEA level that's linked with colorectal cancer and maybe a cancer marker that can be tracked for recurrence in the long run. Surgical resection is a primary module of treatment. It offers the best chance of cure. For stage 3 or below colorectal cancer, the first usually is surgical resection, maybe with some chemotherapy, either around before the surgical resection or afterwards. Nowadays, even for stage 4 cancer with isolated metastasis to the liver, sometimes the surgeon can still perform limited resection of the liver plus the local cancer, and that still have better prognosis. And also, because of the understanding of hereditary cancer syndrome, for patients who are diagnosed with colon cancer below age 50, and sometimes in some institutions, they always test for a gene repair defect called microsatellite instability. If the patient has that, then maybe they can, or they should be screened for Lynch syndrome or cancer syndrome in the family. I'm not going to talk too much about it, but Lynch syndrome is a syndrome that has high risk not only for colon cancer, but for uterine, ovary cancer, and other organs as well. My suspicion is that we're going to know more and more about Lynch syndrome and other syndrome with time, because there's a lot of advances in genetic these years. And finally, when the patient were treated, they still need to come back to their cancer doctor to making sure the cancer is controlled and there's either no chance of coming back or there's some additional treatment for it. That's the stage called surveillance. And it is this stage they'll also have additional colonoscopies, because once the colon has shown its risk for colon cancer, other polyps can show up at other parts of the colon. So it's very important we do colonoscopy in a year, in 3 years, and then at a minimum every 5 years afterwards for cancer survivors. So prevention. There's no particular recommendation with regard to just lower the risk of colon cancer. What we know is that what you do right for your heart, which is dieting, exercise, avoid the charred red meat, eat a lot of fruits, vegetables, limit the calorie intake, avoid excessive alcohol, and quit smoking. These are good things to do for your heart, and they're the right things to do for the colon as well in terms of reducing the colorectal cancer incidence. There's some good large population-based retrospective studies which have shown aspirin or some of the over-the-counter painkillers like Motrin, ibuprofen. They're linked with a lower risk of colon polyps and colon cancer. However, the evidence is not strong enough that we would recommend everybody to be on aspirin to prevent colon cancer. If the patient happens to need aspirin for their general health or for their heart, it's a good thing to do for their colon as well. And finally, in this country, we recommend screening tests for colorectal cancer start at age 50, or for African Americans start at age 45. The primary module is, or the gold standard is a screening colonoscopy. So this is just one of the cartoons I came across. This gentleman turned age 50. So he's a little depressed, and somebody was working on his behalf. Let him know he probably would benefit from a screening colonoscopy at the same time. Another view of looking at it is I read something from, I think, the New York Times or some other major news article, like your house would need to be remodeled every few years. So when a patient turns age 50, it might be a good idea to remodel the colon in terms of removing the polyps and reduce the chance of colon cancer. How many of you have had colonoscopy done in the past? Well, I'm impressed. Over here. Yeah. Many of you had experience like this one? For somebody who has never had it done, this could be really scary, but I guarantee you this is not the experience at Cooper or any other places who do colonoscopy every day. This is one of the cartoonist views. It's actually true of the early colonoscopy. I'm not sure how many of you actually know about this, but the early scopes, they're not as flexible. They're very rigid. And the colonoscopy or the short scope of the distal colon was done without sedation. So it's very uncomfortable, inconvenient for the patient. And the doctor is not in a better position because he can only look at it through this lens. There's no projection LCD or anything. So it's uncomfortable. It's a little embarrassing. But this is how we evolved in the modern age of colonoscopy. So the patient will be sleeping. I think this is probably most of the experience here. Lying mostly on the left side, the doctor, a gastroenterologist, or sometimes a colorectal surgeon. We insert a flexible tube starting from the rectum and goes all the way to the start of the colon. Once we are sure we're there, we put a lot of air, make the colon as if it's like a balloon so that we can see everything. And we look for the nodules, the bumps, sometimes the flat lesions that are subtle but different from a colonic mucosa. The goal is to remove any polyps we see, because about 2/3 of the polyps are precancerous or adenoma type, low-grade dysplasia type that give time could turn into cancer. And beyond the patient, the doctor, the LCD the doctor looks for, there are actually a couple more people in the room to making sure this is a safe procedure for the patient. Most of the time it's done with the anesthesia team, a nurse, anesthetist who provide propofol and sedation, making sure the patient's sleeping all the time. There will also be a GI nurse with special training in GI to record the vital signs to making sure the pathology is correctly labeled. There's also going to be a surgical tech who will give me all the tools so when I see a polyp, I can make sure it's either grabbed, snared, or removed in the correct way and get sent for pathology. So it's a teamwork. And the procedure takes about 30 to 45 minutes, depending on how many polyps, how difficult the insertion is. But most patients wake up okay. There's a small risk of causing a tear or bleeding. Sometimes we miss the small polyps, but overall it's a very, very safe procedure. And this is what the colon looks like when it's fully clean. It's very important for the patient to clean the colon 100%, so we can see all the little bumps. This is what they look like when the colon is clean. You can see all the mucosa. You can see the subtle vasal patterns, which sometimes when there's a flat polyp, you'll see this vasal pattern actually change. And this helps us with the trained eye to detect the flat polyps. This is an inside look of the appendix. This is how we know we're at the start of the colon. The other way we can know is we can actually get into a valve that connects with the distal small valve, the mucosa change, and we know. We usually confirm by either one or both ways to know for sure where to start the colon. This is one of the recent advances in colonoscopy. If you look clearly, the center part of the colon mucosa has a very flat but different pattern. This is actually a polyp. It's a typical polyp in the right colon that is very, very subtle. If you do CAT scans, if you do any imaging studies, it may not show up because it's not going to pop up. But we think this is why the reason in the previous studies, especially the studies from large cohorts in Canada, they're showing colonoscopy is very good at reducing colon cancer in the left colon, but not so good in the right colon. And we believe this is the reason because the polyps differ. Their size differ. There's more flat polyps in the right colon. So when the patient does a good job of cleaning the colon, then we can take a very good look and looking for these subtle polyps in the right colon and remove them. This is another advance with the colonoscopies that we're becoming more and more capable and competent of removing large polyps. This is, again, a relative flat polyp. It's spread over the fold. In old times, we may send these patients to the colorectal surgeon colleague to resect part of the colon to take the polyp out. But nowadays, what we usually do for a polyp like this is we put a needle, inject water or saline or some lifting agent, liquid, and make the polyp kind of raise up and make it a bigger bump. And then we usually use snares to cauterize it, and then we can resect the margin, sometimes using laser to treat the margin, the residual polyp. And if we think the risk of bleeding is high after we take the polyp out, we can put metal clips to close the defect as well. So we're getting more and more comfortable reducing colon cancer by taking large polyps like this endoscopically and save a surgery. So there are alternatives for screening, and all these 4 other tests are recommended by the U.S. Preventive Service Task Force and by professional cancer societies. They're all acceptable, but they're not as good as colonoscopy. The first test is looking really for blood in the stool. It has to be done every year. Depending on the test, sometimes we may have to do 3 times in the same year on 3 different days. It's a very good test to detect early colon cancer because large polyps usually do not bleed. So for polyps, this is not the best test. The best test still is colonoscopy. But for anything invasive, when they become invasive, they can lead to a slow oozing situation. The patient may become anemic and has blood showing in the stool. So this is a very good test. It has the same effective rate for detecting cancer as a colonoscopy. But it needs to be done every year, and it's not a good test for polyps. The barium enema, which is getting the barium, try to get it through the colon, looking again for any bumps. It's a reasonable test for colon cancer, but anything flat on the right colon, because the barium takes a long time to get through that, it's only about, my best guess is probably only about 80 to 90% sensitive even for cancers, especially the early ones. And patients can go through the same prep and then have a CT done, and the radiologists actually have special software after they do the low-dose CT, they can reconstruct the colon mucosa, and again, looking for bumps. So for flat polyps, they may not be as good. But there's some good studies published in New England Journal of Medicine showing for polyps 5 millimeter or above, CT colonoscopy is actually a very sensitive and good test. And it's about the same detection rate for polyps over 5 millimeter in size. But if the patient has any polyps like that, then they will need a colonoscopy either on the same day or at a different time to remove the polyps. Only colonoscopy is a test that's both diagnostic and therapeutic because we can remove the polyp at the same time of the procedure. And finally, this has been done less and less, but it's certainly doable, which is a flexible sigmoidoscopy, only looking at the left colon and looking for polyps as well. All these tests, the first one requires annual tests. The other 3 are recommended to be done at least every 5 years. For colonoscopy, if there's no cancers, or precancerous polyp, it can be done every 10 years. When a patient has adenoma or low-grade dysplasia, or a couple of them detected, then they may have to get it done every 5 instead of 10 years.
Question?
Yes.
So if you have a family history, like my dad died of colon cancer, we recommend that I do that every 5 years. Are you in agreement with that, or you think I can wait to the 10th year if I have not shown any polyps?
I think, and I believe, it's still every 5 years because you have a first-degree relative.
Okay.
Which is different from a second-degree relative. And also, the risk also depends on, it's more personal, and we can talk a little bit more. It also depends on when the colon cancer was diagnosed.
Okay.
The official recommendations 10 years before a first-degree relative was diagnosed with colon cancer or age 50, whichever is early.
Okay.
But I think every 5 years, probably, at least for the first couple, and later on, maybe we'll learn more. We'll be more able to predict risk in the future, but probably in 5 years, for at least the first couple, just to be sure. Thanks for your time.